Senior Consultant and Infertility Specialist, SAT Hospital, Government Medical College, Trivandrum.
Dr. Parshuram Gopinath, Senior Consultant of Saimar Group of Hospitals. Dr. Nirmal Krishnan, Infertility Specialist and Medical Director, Care Hospital, Thrissur.
We welcome all the panelists to the stage.
It's okay? Yeah. Very good evening to all of you. And just moving away from all that obstetrics that we were having so far, we are having a small panel discussion. And I decided to move away from that podium here because when you're having a conversation, I guess it's better to be closer to the people with whom you're having a conversation. So, and today we have a very distinguished set of practitioners here who are Ashwath, Parshu, Reggie, Fesi and Nirmal. You cut 5 minutes from mine, it's 50 minutes I think, so that's why I am cutting short on their introduction. So we'll go ahead. First, before going ahead right on with infertility, we'll just go to fertility, and then this thing about maximizing fertility, many doubts and few tips. See, this our discussion today is for general practitioner. So I guess that, you know, we take the scenario of a couple who have come, and then, you know, they were planning and not wanting to have children so far, but have decided to have kids, and they're asking regarding a few tips regarding maximizing fertility. So you could just get over in a blast. The first two are always what patients ask. I think everybody will agree. Engana bandhapadanam, endu cheyanam, matte marche, and endu kazhikkanam. This is patient's doubts. So Ashwath, we'll start from you. Yeah. Your tips, secret tips for conceiving fast.
See, coital practices, what I think Venu means is that, see, we tell, patient may ask you that when to have intercourse. So mostly we use only two methods, either by date, calculate if it's a regular period, we'll have from 6 days, from 10th to 16th day, or we use LH kits. That is how.
You are using LH kits?
I am using.
We'll just go across the board. Yes, come on.
So, usually do is that first visit itself, I explain how the fertilization occurs.
Correct.
Because it is the basic things they have to know.
Yes.
And tell not to restrict by the ovulation day by doing either LH kit or that.
Yes.
Just forget about that.
Correct.
Just to try having normal,
point to be taken,
normal at least alternate day sex if we are not having period.
Correct.
So anybody, that will relieve the tension.
Anybody
Otherwise
wants to add anything regarding that? Nothing to add, but patient wants to know many more things. Yes?
No, what I basically tell the couple is basically forget about that ovulation and all those things.
Correct.
You just enjoy sex.
Correct.
Okay. And after once she is comfortable with after periods and all weather, any day, just like Fesi told, every 2 or 3 days they can have. And they can, there's nothing much, you just enjoy sex and...
Yes, I think we drive the message that pinpointing a date for having a relationship is a disaster because many times...
Venu got an important point about the important thing, when most of the people ask, I usually tell that the semen usually it is 2 or 3 ml, but only the sperms goes into the uterus.
Correct.
That is the important.
Many
thing.
patients patients will say, "Okay, ഒഴുകി പോണ്ട, it's going." Means poor things, you know, they're
എന്നാലും ഞാൻ പറയാറുണ്ട്, when then I usually tell them that, see, to their satisfaction, I tell them to keep a pillow below for some half an hour.
Diet.
Diet is that only they should not take alcohol, and that is smoking and all.
See, alcohol is not part of diet. That's my information. Yes.
And diet means a good protein diet, that we agree. Protein
Any
diet.
special diet? Apple, banana, mango, pineapple.
I would recommend balanced diet.
Yes.
Containing vegetables,
Correct.
whole grains,
Correct.
Red fruits and vegetables.
Yes. Anything that it's good, sprouts. Yes. Red
Yes.
colored, antioxidant
Yes,
rich.
red fruits and
diet.
vegetables
Yes.
especially.
Yes.
And act as good
Anything to
antioxidants.
yes, antioxidants. So that's, I think, very important. No, that kind of diet. Patients always ask this, and what's good and this thing. Very important. Supplements. Any supplements you recommend?
Unless there is a proven nutrition deficiency, then there's no need of any
No need for supplements. Lady, you will advise to take folic acid, right?
And especially-
yes.
Especially men who come to us, some നമ്മൾ പൂജാരിമാരൊക്കെ ഉണ്ടാവില്ല.
Puja.
So this Osimum sanctum, they usually have leaves of Osimum
തുളസിയുടെ ഇല കഴിക്കുന്നത്.
Yes, that is particularly പറയും പൂജാരിമാരാണെങ്കിൽ, because they continue to consume it. It results in severe necrospermia and azoospermia.
Yeah. Correct. So that's what I wanted to take out. You know, everybody will have their own favorite tips of telling patients.
Since you are told about this thing, what are the occupation things which you have
Yes.
to be clearly seen in the history? Usually those are painters or those are especially spray
Yes.
painters,
High risk.
polishing.
Yes.
And another thing what is common in this part of our state is those who are working goldsmith, not because of the heat, because of the chemical they use, the fumes. That I have seen lot of patients
Correct.
with degrees.
Painters, varnish and exposure, all these things. Yeah, Reggie? Yes.
No,
Welding? Yes.
anything, any work, avoid stress.
Avoid stress.
avoid-
Otherwise, Reggie, stress avoid ചെയ്യാൻ ഒരു peg ആയാലോ?
ഒരു പെഗ് ആയാൽ കുഴപ്പമില്ല sir. One peg is fine.
Patients ask,
See, alcohol as such, the dose is the problem. Okay, as
dose?
such, yeah, dose of the alcohol. Okay.
So what's your optimum dose?
Nothing like that. Anything. Actually, physicians they tell,
No,
they advise red
you.
wine and all.
You, huh?
They advise red wine and all. Red wine
You
and
are
all.
also
no,
advising red wine?
No, nothing like that. How people are not used to red wine and all.
Nirmal? No, this is, see, in Kerala you have to discuss this. People will ask you, ഒരു peg out and just കുറച്ച്.
അല്ല, പണ്ട് പുസ്തകത്തിൽ എഴുതിയായിരുന്നു ഇറ്റ്സ് ഗുഡ് ഫോർ ദ ഹാർട്ട് എന്ന് പറഞ്ഞായിരുന്നു, പ്രൊട്ടക്റ്റീവ് റെഡ് വൈൻ ഓർ ഹാവിംഗ് one peg of whiskey. But currently it has been conclusively proven that any amount of alcohol is harmful.
Any amount of alcohol
Any
is
amount of alcohol is harmful. But നമ്മളത് അറിഞ്ഞു കഴിക്കുക.
Any amount of alcohol is harmful, Nirmal says. Nirmal അടുത്ത് പോണ്ട. Fesi?
I agree to what Reggie told. Little is okay, but it must not
In
be
moderation.
addictive.
In moderation, not habit. And what about this binge drinking? പെരുന്നാൾ വരുമ്പോൾ മാത്രം drowning or something like that?
That's also not good.
Is to be
It is not
discouraged
advised.
because
Yeah.
yes. And കൂടെ wife കുറച്ച് ഇത് കഴിച്ചാലോ? Vodka?
Good for family harmony.
No. What about good for conception?
No, that's what evidence has said, that any amount of alcohol is harmful for.
Yes, especially for the
any
ladies.
amount.
Yes,
Evidence
for the
says that.
somebody
The
is
current
talking
evidence is that.
Parishu, alcohol വന്നപ്പോൾ silence. Yes.
Amount of alcohol is considered to be okay.
Yes.
But I like to slightly focus a little more back on what we were telling about the frequency and this thing.
Yes.
Because it's also important that we communicate to the patient as to why we are telling this.
Correct.
So whenever we tell a patient that try to have, say, rather than timed intercourse, the benefits are when you're having a regular sexual life. When I say regular sexual life does not mean having sex every day. At least 2 to 3 days once, because the sperm has the survival possibility of 2 to 3 days.
Correct.
So whenever the ovulation happens, the possibility of sperm is there.
Correct.
So a regular sexual. Second, as far as a male is concerned, when you're actually giving them a very focused time of intercourse, it's unnecessarily causing a lot of stress for them.
Correct.
So when you're having regular sexual, then it
See, that
becomes
is,
a
I
part
think,
of
very
the thing.
important point to make, because nowadays many couples don't have this sexual habit and
See,
this, stress and this thing means that, yeah?
Yeah, and one more thing is that I think they plan too much, the
Correct.
couples today. See, what happens is when they have regular sexual life, they don't want to have a child.
Yes.
When they want to have a child, they only have sex for the child.
Correct.
So I think that is something that people
Correct.
should
And
understand.
when to have sex also, they will take out the mobile and say app.
They look at an app. See, if you know that, if you realize most of the PCOD patients who have cycles 2 to 3
Yes,
months
yes.
will come having regular sex on the 14th and 15th day, 16th day. They come back to us and tell us that, okay, we're not getting
Exactly.
pregnant.
Periods LMP അറിയാനും കൂടി ആപ്പ് എടുത്തിട്ടാണല്ലോ പറയണത്.
That's why I told first visit itself, we will tell how the normal ovulation occurs,
Correct.
how the periods occurs.
Understood.
That
Got
is
it.
very
So
important.
yeah, that's right. Now those are the two things patients want to know. What do we say about your body weight and things like that? Are you giving importance to these things for somebody? We're
Body
not-
weight, see, excess body weight, that means BMI, high BMI, as well as low BMI. We don't encourage both.
You are
actually.
going worried about both. I think there should be consensus regarding that. That for it's bad. Any special points to make about BMI?
Especially if the cycles are irregular.
Correct.
That will be really
Correct.
a matter of concern.
Correct.
Plus,
And then-
also just we are talking about all the coital practices because obesity is found to be affecting the coital practice to a larger extent.
And then what is, Parsha, I'll ask you one question. What will you tell to somebody when you tell about BMI and this thing, they will tell you, എല്ലാവർക്കും അങ്ങനെ തന്നെയാണ്, അമ്മയ്ക്കോ അതെ അമ്മായിക്കോ അതെ എല്ലാവർക്കും കുട്ടികളുണ്ടാവും, ബുദ്ധിമുട്ടുണ്ടായിട്ടില്ല. And here BMI is 35, more than that, 36, 37.
So that is where I was coming at. See,
Yes.
it's very important to tell them to try. Scaring them saying that you are heavy, you should lose weight. Scaring them to say that you are too thin, you need to gain weight before pregnancy. It's nothing like that. Let them try for a pregnancy. If they don't get pregnant, probably that time we can look
Yes,
at all
because
these
this
things.
is not
We are
yet-
unnecessarily creating a lot of stress for them, telling
Yeah.
them that you have to be of particular type, then only you can conceive.
Correct.
Nothing like that.
Yeah.
However people can conceive.
Yes, you don't have to be a particular type to conceive, but you can make them aware of the problems of excessive BMI becoming pregnant and this sort of things, no? That thing, and so
Suppose if the BMI is very high and all, you can't give them within 1 month or something like that. You have to
Correct.
lose the unnecessary stress
correct,
it is causing.
Correct. So I think that's a reasonable sum up of the,
Focus on male also. You have
Yes.
to tell the male also. Suppose if it is.
I agree. Yeah,
Yeah.
male is equally important as a female. Yes.
Male obesity, we are seeing a lot of cases of male obesity with low testosterone
Yes, correct.
and low sperm count.
Correct. Now we have a lot of these people working with sedentary lifestyle and this thing where this is a real problem. Not any.
Even there are, coming to the, I think that will be covered later, medical management. After this study of letrozole for testicular estradiol ratio.
We'll come there. We'll come to that. Yeah, we'll come to that. Now we'll move a little bit away from that. The next point that, these are just sort of few observations regarding diet and all that. But then I think I don't need to put up these slides because they've answered and discussed these points so nicely. We'll come next to this. This is very important because we have a gathering of practitioners here who are general practitioners, and I see when we are practicing IVF, we are all very conversant regarding the new laws regarding infertility and its treatment. But many of the general practitioners are still, because I go to few places where I still see IUI being done in labs and this sort of things. I just want Parishu. Can you just have this thing, because Parishu actually follows this thing. How is the new, we don't want a discussion on the ART bill here, okay, but then we need to know how it has impacted infertility practice, and do the rules, just the general practitioner or the gynecologist need to know about it, and what should they be careful about?
No, it's very important that they know about it, because
It's very important, so I
it's
think
very important that
yes.
they know about it, because I think they should be also knowing as to what group of patients they can treat, or
Correct.
up to what level they can treat to.
Correct.
Because a lot of people used to do a home insemination or intrauterine inseminations in your clinics,
Exactly,
in your
yes,
homes.
yes.
So now you know that it is not possible unless you actually register for in your in the
Correct. Anytime you want to handle gametes outside,
as a level 1 clinic, and if you need to do an IVF for ICSI or something like that, you need to be registered as a level 2
Correct.
clinic.
And
Previously, semen was prepared in some lab and it was been transported to their clinic.
still it's going on.
But it
Yes.
is not allowed. That is most important.
Yes.
Then to do any sort of ART procedure, the age has to be 21 years.
Yes.
That is another thing.
Yes.
So if somebody comes less than that, you are not supposed to do it.
And the opposite, if it's a male 55 and female 50,
Yes.
opposite also, age also.
We should ask the age of the patient.
And
Yes.
this is, as Parishu told correctly, the most important is that the practitioner should know that to what extent they should. See, if you are not doing IUI, if you are not doing IUI, you don't have to register.
Now,
actually.
for those who are coming for IUI and IVF, we collect their identity, like Aadhaar card or something,
Yes.
and for their marriage certificate also, because only
Yes.
the marriage
So you've
couple can-
registered. Ashwath is not doing IVF, so you've registered. You registered.
I am not doing IVF, but I have registered
You have
for
registered.
one, that
You
is
register.
level 1.
So does people who are doing ovulation induction also need to register?
No.
That's
Venu,
the-
Venu,
Yes.
can I ask a question?
Yes.
Can we deny this thing, infertility treatment to them? I think it's only for the ART thing.
Yes.
But suppose if a guy comes at 56 and
Correct.
you're telling that you can't treat them, that we can't deny. We can deny them ART.
You can deny them ART.
ART,
Yes. Yes.
not the infertility
Yes.
treatment.
Yes.
No, yes, correct.
Yes.
correct.
Correct.
See, I think for people to understand now what is ART is.
That is very important here.
Taking the semen gametes out of the body, then only we are talking about ART. So for example, handling the gametes outside the body. So if
Correct.
you're talking about an IUI, you're taking the sperm and handling it outside and putting it back.
Correct.
So only those kind of procedures are involved. Your
Correct.
regular inductions are also. See, when we also talk about the importance of a marriage certificate or not even a proof of marriage, or more importantly an Aadhaar card. And today what is also important is that you also have some provision in your own clinic to actually have a authentication of your Aadhaar card. That's
Yes.
also possible today because
So-
recently if you realize there was a big case that came in all papers where they were actually utilizing minors for
Yes,
egg-
yes,
egg-
no,
this thing.
definitely, definitely.
So we should start
So
from there
we,
also.
the practitioner needs to know that there is a law which governs treatment, especially when it comes to ART. ART does not mean only IVF. ART also means IUI. See, this is also very important to understand. And then the age is also important for ART. But then there are few people, again, when you're, see the ART law, see the selection of patients, again, when you're sending people to an IVF specialist for doing ART, there are few people who cannot receive these services. You should know that. That includes unmarried men, divorced men, widower men, heterosexual couples, married. Most importantly, your live-in relationship and all these things, no? Any observation, agreed? This all you should know, homosexuals, transgenders, because nowadays, if you're treating, you have a whole range of people who come and ask. And then people are very vociferous about their reproductive rights. They want to have a child, yes.
That is why they were telling marriage certificate has to be
Correct.
shown before ART.
Correct.
Now to add little confusion to this whole debate.
Confusion?
Recently we had the legalization of marriage of transsexuals to another person. So now that marriage has become legal. Obviously, if, for example, a female who's probably has a mindset of a man can actually get married to a female. Now that is an official marriage. Now this has recently been sanctioned. No, Supreme Court order.
It was cancelled in the.
Go ahead.
I thought it was there.
It was cancelled in the.
പോട്ടെ അത് ഭയങ്കരമായി പോയി ജനറൽ പ്രാക്ടീഷണർ will moment they come you send to Parishu, okay?
Also, foreign couples, I think, should be denied. Foreign couples.
Foreign nationals are denied surrogacy, not treatment. This thing, So, but see, when the patients come, you should know there's an act, there's a law applicable for IVF. It's there for this thing, and we should be aware of it. General practitioner level, doubts you can ask. But age has become very important. All these things are important. Next, we are coming to male infertility, okay? What every gynecologist should know. Before we go to male infertility, what every gynecologist should know, sitting in centers treating a lot of infertility patients, I will ask Nirmal, Fesi, Reggie and Parishu, are you satisfied with the way evaluation of the male partner is being done as of now, or do you feel there are few lacunae, or you feel things should have been done better?
As a first line, when the male patient comes, basically there must be semen analysis.
Are you satisfied with
Most of the time, the male is not evaluated at all.
That is what, yes. Yes.
I see. Not
You see that?
Yes. A lot of cases, males are not evaluated.
Yes.
Patient comes for treatment to us for endometriosis, but male will have azoospermia.
Correct.
Which was missed.
Correct.
So that is not the case for all, but I've seen a lot of cases like that.
So
where a
you are
primary
finding
evaluation
lacunas in the treatment of the male. Fesi, are you finding gaps?
Yes, definitely. I think I have seen like this asuspermia patients which has not been evaluated.
Yes,
which-
lots of such gaps are there because the evaluation. Reggie, Trivandrum എങ്ങനെയാ കുറച്ച് better ആണോ? എന്താ what's?
No, no, definitely you have to take the history as well as the
No, are you finding gaps or this thing? You
yeah,
find it sufficient?
yeah, you're focusing more just like ഒരു എന്താ പറയുന്ന മീസോഗൈനിസ്റ്റിക് ആറ്റിറ്റ്യൂഡ് എന്നൊക്കെ പറയുന്ന പോലെ തന്നെ. Now again, so many are blaming on the lady, not this thing. You have to look into problems. Almost 50-50. It's
No, obviously, yes. Unfortunately, fertility people come to gynecologists. And gynecologists generally are not trained to examine and evaluate a male
Yes.
to a certain extent.
Yes.
But I think there has to be some effort that has been put into understanding how,
Yes.
because these are things which we have studied in our MBBS, but probably not in your post-graduation.
Yes, yes.
So basic understanding of your how to examine a male, how to evaluate their blood evaluations needs to be done.
Yes.
Second very important thing that is a big lacunae that we always see is that general gynecologists do tend to send semen analysis to every random labs.
Yes.
So for
We'll come to
example,
that. So
that
you are
standardization
yes.
of semen
is
analysis
not there.
becomes a
Yes.
major.
Now Ashwath, ഞാൻ ചോദിക്കട്ടെ that this, how many males that come to you that they have been examined?
What I have seen is that so maybe first they come to my side, then they go to
Yes.
the IVF
Now
centers.
I will ask you a more pointed question. Now you are working in a center, you are a male gynecologist, and a lot of your colleagues are lady gynecologists or female gynecologists. How many of them examine a male patient?
അല്ല,
അത്
most of them,
പ്രശ്നമെന്ന് അറിയാൻ ചോദിച്ചു.
അതല്ല. I don't think they are regularly examining natural. They are examining many
Why
of them
natural
send to
means
me.
what?
Many of them send because I am there on the other side of other OP. They usually send to my OP to examine
Why?
the
But
male.
why?
Usually, and I don't think all the patients have been evaluated.
Why I want to ask all the gynecologists, why does it happen? Then why you have to send to Ashwath? Why cannot?
No. It is a normal, usual practice that is being. Many times the males are not being properly evaluated. What we are
not
saying.
properly evaluated, no?
Males are not properly evaluated.
Why does it happen that the lady gynecologist does not examine the male
That's
patient?
why, as a part of our specialization, whenever
I
we are
wish there
training,
was a female
so
gynecologist.
first thing we teach is that how the males, just basic examination of male is being made them understand. That is very important.
No, we will just ask for a raise
Most of the
hands.
time,
Put a raise of the hands to how many of the female gynecologists here are examining a male patient? അത് കണ്ടുപിടിക്കാൻ മൈക്രോസ്കോപ്പ് ഉപയോഗിക്കണം ഇതുപോലെ.
അതിൽ കാരണം എന്താ വേണു, they have a misconcept that everything can be detected in a semen analysis എന്നുള്ളൊരു പലർക്കും that I felt that
മിസ്കൺസെപ്ഷൻ അല്ല, ഇവരൊക്കെ മിസ്കൺസെപ്ഷൻ.
So that technically it's not a misconception. Nobody knows, or probably they're not very confident. You are always
Confident. What
hesitant
confidence you
you are
want
hesitant
to? What confidence you require to examine a male? Poor fellow will be standing and trembling like this one.
like generally.
The message to be given is the male partner deserves an examination, because the first point of contact is always invariably not our group of people. Invariably the first point of contact will be a gynecologist, a lady gynecologist who will be there, and most of the time that doesn't happen. So many
Second
times.
thing, along that we have to add that examination is better, or for all the studies have been proved better than the ultrasound. Some people
Yes,
just,
no,
just,
this
just
is
send them for
examination. See,
ultrasound.
so many times you just examine a male, you will find undetected hydroceles, undetected this thing. Yes, testis of, yes, so there's so many things. You agree, Nirmal? That is.
Sir, one thing that I would say is that not necessary that, but at least basic thing is do a semen analysis. If you see an abnormality, please evaluate the male. At least that thing
exactly,
is, at least that thing you should
There
do.
is always there is
Not
that
necessary that
point.
every couple that comes to you.
At least convey the message that an examination is necessary. Okay, examination is necessary. The next best thing to examination is to send to somebody like Ashwath. So he is happy, everybody is happy, a win-win game. But then many times that doesn't happen. What happens is the patient is referred to a urologist, and which is the worst possible thing to happen. No? Do you agree that?
I agree. Urological evaluation is entirely different. Then a patient which doesn't get, see, when we are examining, we take it as a couple where the results are always better.
Yes. No, yeah, urological.
Urologist will
like I said,
recommend
how,
urologist will recommend an ultrasound.
Urologist-
Then they will find a grade 1 varicocele.
Yes.
For which they will do surgery.
അല്ല കാരണം for the urologist, ഈ മാഡം ഇത് പറഞ്ഞ അയച്ചു നോക്കാത്തതുകൊണ്ട് എന്താ കാര്യമല്ല. ദേ ഹാവ് ലോട്ട് ഓഫ് അതർ ബെറ്റർ തിങ്സ് ടു ഡു. ദേ ഹാവ് സ്റ്റോൺ, കിഡ്നി, ഓൾ ദിസ് തിങ് ടു ഡീൽ വിത്ത് യുവർ.
Just like how I said, gynecologists don't have an idea or probably a process in which they need to actually evaluate a male.
Yes.
Male, the urologists don't have a process to evaluate an infertile male.
Correct.
Probably they look at different aspects, but they don't really look at
Correct.
fertility.
Exactly. So
In
that's
our, in our country, the biggest problem with male fertility evaluations, as Parashu said, lack of standardized laboratories.
yes.
Because even in Spiroff, they
Yes.
say first you do a semen analysis. If it's abnormal, examine the male.
Yes.
That's how it's said
Yes,
in the
yes,
textbook.
yes.
But if you go by the textbook also, you do not have somebody who can
Correct.
examine the sperm properly.
Correct.
It's very subjective thing.
No, we don't spend time. Now see, you're talking about examination. How many of the patients, male patients, are asked about coital history? How many
that's
male
often
patients
missed.
are asked about coital history? Have you found, sitting Parashu and Fesi and Nirmal and this thing, how many times we find patients who've done 3 to 4 IUIs, 1 or 2 IVF without even having had sexual intercourse properly even one time? Are you going to agree with it or are you going to
Agree.
Agreed.
I had a patient first initially, yes. 6 months I was evaluating the patient. They're giving medicines, induction, everything. Finally
you discovered that.
finally one day he asked some funny question. Then I asked how many times you had. So he was not even having idea where to have sex.
See, you took 6 months. Then can you imagine?
Because he never was revealing things.
If you remember the movie Dr. G, the wife is trying to say that the husband is always saying that, okay, I'm doing it several times. Then a wife is trying to imply the doctor, yes, he's trying, but it's all in a different direction. so that kind of an information, probably sometimes we might find it funny, but then it's important that we kind
Very
of
important,
probably
very
tell them
important.
that where the penetration has to happen, penetration has to happen.
When he was, actually this person was a security in one of the hospitals here, imagine. And the next month itself he became pregnant.
Forget
They became
having sexual contact. You asked to give a semen sample, and then the man will look at this staff standing around and think that semen sample കൊടുക്കുക എന്താ ഏതാന്ന് പറഞ്ഞിട്ടില്ലേ ഉണ്ടാവാറില്ലേ അങ്ങനെ
Correct.
ഇല്ലേ
The other
as
way-
though we are supposed to reproduce sample and give.
I like to add a similar story. Once,
Yes.
one senior gynecologist referred a couple who is
Correct.
relative to them with sexual problem.
Yes.
So I was trying to correct their sexual problem.
How is that?
Then, by counseling, taking a detailed history, I had to find whether it is the basic reason what it is, whether it is erectile dysfunction properly, or it is whether it is vaginismus which is the problem. Then you have to slowly correct it. But after 1 week, when that gynecologist called me, then I told I am trying to correct. You just do an IUI and finish it off. But that is not the thing, because
Yes.
once it is not corrected,
Correct.
it will not get corrected.
Exactly. And then see, these all things are small things but very important, no? So see, we have taken out 4 lacunae in the evaluation of the male. One is an improper or a not so ideal semen analysis. Second is, other lacunae is, beyond semen analysis, lot of investigations done for the male. Scan will be done, hormones will be done. Third is a bucket full of medicines will be prescribed to the male. And fourth is an ultrasound report followed by a surgery has been advised. These are the 4 lacunae. From Nirmal we'll start that how do you look at a semen analysis and you decide that, see, not in your lab, okay, you have a wonderful facilities and all that, but you see a semen report from outside, how do you decide it's a good report? And I'm not asking count, and we are not going to discuss values and all that. ഒരു semen report കണ്ടു കഴിഞ്ഞാൽ ഒരു reasonably good
At least the way they have reported
yes
the values, you see that they have some kind of experience to reporting semen. Most of the time I see is very vague reports and very this is highly subjective. Semen
Yes.
analysis is highly subjective.
Yes.
Anybody, so 3 lab technicians will write 3 different reports.
Correct.
So most of the time I get it repeated from my place.
Yes.
At
You
least
will
once.
get it. No, yeah, you'll get it. But sometimes you have reports from abroad. All
Yeah,
these things.
So the reporting,
anyway,
the way they report it.
So the minute you see 90% normal sperms, you know the report is wrong.
the moment you see,
If you
yes,
see more than 70-75% normal,
Correct.
Very
that
high
is not
counts.
correct.
correct. Morphology often gives you a clue.
Then whether they have stained and see, if they give
Correct.
the report within 2-3 hours, that
Correct.
means they are not stained the sample.
Correct.
And,
Ashwat,
my observation is that, see, whenever see, I get reports from all the labs.
Yes, yes.
So whenever I have any doubt, I send to an infertility IVF center to do the semen analysis.
Yes.
So don't think it's not referring, but just maybe go to IVF center to, because that is nothing, because the reports are very specific. We are sure that the reports side.
ഇത് അശ്വതി ചുമ്മാ പറയാം, ഞങ്ങളുടെ ഒന്നും വിടാറില്ല.
Basically, see, semen analysis, again, with a single semen analysis, you can't comment.
You
What's
can't.
the first thing?
Exactly.
Second thing, again, it will depend upon the abstinence,
Yes.
the one which lab it is done and
Yes,
all, whether
yes,
it is
yes,
collected in
yes,
a proper bottle.
yes.
And when it was examined, suppose if it is examined after 1 hour or 2 hours, again,
correct.
it matters.
Correct.
So
See,
many
the point,
things.
the point Reggie made is very important, I think. You have to benchmark a few labs around your place of practice. അതായത് നമ്മുടെ practice, അല്ലേ?
Now
That
itself,
means that-
even now you can see 1990 WHO criteria.
Yes, yes.
1990.
So you have to benchmark a few labs. That's the tip
So
to
which
be given.
criteria they were
Yes,
using?
and
all
in
those
your
things.
own lab, you have all the facilities. Obviously, all of are working in IVF centers. Yeah. Go.
മിക്ക റിപ്പോർട്ടിലും even if there will not be anything, no reference value, nothing.
Correct.
ഒരു 4, only 4 or 5 things will be written.
No, in your own lab, you have reasonably good technicians who are trained. Pursue ideal training എന്താണ് ഒരു technician semen analysis ചെയ്യാൻ വേണ്ടിയിട്ട്?
Basically, obviously, they need to have a complete idea of how the process has to be done.
Yes.
They have to be trained.
Yes.
For example, the latest WHO actually kind of, for example, major training is required for actually kind of reporting the morphology and things.
Correct.
Like that. So one thing that has really changed in the last 2020 WHO semen analysis manual is basically about each process, how it is. A lot of times, initially, each process was 10 minutes centrifugation before that, then only check.
So we need to sit with them.
Yeah,
We need to sit with them
standardize
and get it.
Images. If you look at the last seven analysis, you have lot of images
Yes.
to actually determine and tell them
Yes.
that this is the abnormality
Yes.
that we are talking
Yes.
about. Otherwise, it's all an assumption.
Correct,
You always
correct.
think that, okay, this
Correct. You need to sit with them and say, now Nirmal, you are having a lab person doing it. Now you are having a sort of a semi-automated or semi-quantitative assay. Can you just tell that which one are you more satisfied with? I won't ask you which one is nice, but I'm asking you which one are you more satisfied with. That is it automation? Because see, you'll have a lot of people vending and telling you this is better, this is better. So from your experience as a
So
person who
automation to an
transitioned.
extent, very low, if you are very
Automated എന്ന് പറഞ്ഞാൽ ഞാൻ പറഞ്ഞുതരാം അതല്ലേ ഒരു
computer assisted
ആ.
semen analysis,
Ah.
mostly done by high magnification optics.
അല്ലാണ്ട്
This is to the
yes, are you think the earlier one is better than the next one?
So I'm seeing more good counts
Huh.
with the automated system,
Correct.
and also some bad counts.
Okay.
But it
As
is not,
otherwise, it's mostly an average somewhere, and also this is not good for very low
See.
counts, very low counts, like less
ശരി
than
അപ്പോൾ
1
അത്
million.
ആ ഓട്ടോമേഷൻ ഇല്ലെങ്കിലും അശ്വത്തിന് വിഷമപ്പെടേണ്ട
And
ആവശ്യമില്ല.
if at all the morphology is low, we do it manually.
No, so the Parishu?
called the cost.
No, it's important. Yeah.
So when you're talking about cost versus what you're going to benefit out of it, probably we still not have any proof to say that automation is going to give us any beneficial
Correct.
or any extra report
So
or any
somebody who
extra
doesn't
information.
have an automated system need not feel very
they're
low
absolutely
about it.
correct.
No, need not feel very. Yeah, Ashwat.
Well, I just doubt to you that it is not written in any semen analysis about that it's automated, used or manually.
No. If you look at the reports, you can come to know. If you look at the reports, you can come
Reports,
to
because
know.
we don't have the automated system.
No, we also
The
don't.
automated reports do have that special report which they talk about
Correct.
the motion
my
of
understanding is if you have large volumes and this thing and
See, if the high volumes or low volumes with
Yeah.
lot of debris, lot of error in reporting is there when you are actually doing automation.
Correct.
So that is why it did not really pick up in your general
fine.
circumstances.
Fesi, next is we'll go to the next thing. We're not getting stuck there. Beyond semen analysis, without much thought, you see some patients having a battery of investigations done, hormonal investigations, ultrasound, all these things. What are your thoughts about it? Quickly.
This hormone only indicated if the count is less
Yes.
than 5 million.
Wonderful
And
point.
that too only FSH,
Yes.
LH,
Yes.
then testosterone.
Very
Then
basic hormones.
Now estradiol also because
Yes.
of that reason.
Yeah, you are
study
having
which
that.
is-
But that is a next level, no?
Yes.
What
Also, we
they-
have to rule out diabetes, HbA1c
Correct. And then ultrasound. Reggie, ultrasound.
Ultrasound, if there is a if there is a varying count, actually, if the semen analysis between 1 and 2 is varying, then definitely you have to rule out a varicocele. Again,
why
if
you
you are
want to do ultrasound for that?
no, you have to examine.
Huh?
A proper history is
Ultrasound?
the most important thing is first proper history. Second, you examine the patient, and if you are suspecting only, or if you are not confident in diagnosing
So,
a varicocele.
no routine ultrasound?
No, nothing.
Hormonal indications for a few, especially if you suspect testosterone levels are low, then we'll think about it, count is low, right? Okay.
Yeah.
So that's the point to be made. See, when you're
And
talking
again,
about
in the history, suppose if there is a loss of libido or sexual problems, then you can do a prolactin.
History will
Definitely,
tell,
definitely you
yes,
can do a
yes.
prolactin. There is no harm in that.
History
And
is
if he is looking hypothyroid or something like that, definitely you can do a TSH. There is no harm in doing that.
Also, I feel searching for subclinical varicocele is not required.
not required, yes. It's a very big message
If it
to
is
be done.
clinically visible,
If you have to search for it, then you need not do much about it. No, that's the thing. Like, that's the point to be made. Yes. Yes. Next point I'm coming to, Fesi, is you are talking about letrozole and you're talking about something like that. What is your approach to medical treatment? Because many a times, one semen analysis showing little bit less count and a big blanket prescription, one antioxidant, one anti-estrogen, one antibiotic, and all of these things. What are your thoughts about it?
All the available antioxidants, nothing is
I
found
didn't
to be
ask one specific
No, all the whatever is available in the market, all the combinations are separate. None of them is absolutely proved very effective. But it can be given as a trial just before going for an ART.
Okay.
And just tell the patient that it is just for a trial because antioxidant.
Okay, that's to antioxidants. But I am telling, how do you approach it? Do you have a way to approach patient before?
No,
Because see,
then
yeah.
definitely if there is a bad semen analysis patients with hypogonadotropic hypogonadism,
Yes.
those patients will the only group of
Yes.
patients
Only group of patients
which will benefit
will
from
be,
the
yes,
from the hormonal therapy.
which are unlikely to be diagnosed by general practitioners, right?
Yes.
So your injection, this thing is less going to be in that group of patients. Yes.
I usually give all these things actually.
Actually, you
Antioxidants, antioxidants.
See, I find a little bit objection to this word used, that I usually give all these things.
All this means antioxidants as well as coenzyme Q and all these things I
And
give.
things are another.
Drugs which will give. And but about I asked about the antibiotics, I give only if I do a culture, that is antibiotics.
So
Yeah.
when you evaluate the male,
Yes.
you see the count and you
Yes.
think it's reliable.
Correct.
Anything less than 5 million or azoospermia, then you go ahead with the hormonal evaluation.
Exactly, yeah.
FSH and testosterone.
yes.
Now you find that everything is normal.
Yes.
That brings to the majority of the category.
Yes,
where
yes.
semen parameters are abnormal, but
Yes.
but most of the hormonal evaluation is normal.
Yes.
In that situation, there is a role for antioxidants.
Correct.
Not too long, maybe 60 to 90 days at max. Too much antioxidants is also not good. One. Secondly, if there is a hormonal abnormality, if FSH is low, then you call that, if testosterone is low, we call that hypogonadism.
Okay.
And if hypogonadism is there, then you have to check what is the cause for hypogonadism.
Correct.
If it's a
Yeah,
high,
we'll come.
yeah.
We'll come. What I want to ask, just before we pass this sort of thing, any mention regarding the male infertility and genetic problems in the male?
Definitely, if it is azoospermia patients, whether it is for obstructive azoospermia or any non-obstructive azoospermia,
Yes.
or with severe oligoacidoteratospemia, definitely there is a role for genetic
Yes.
evaluation.
So the severe the male infertility problem, the more likely to be a genetic cause.
Then
No?
one we missed is that we told we will discuss
Yes.
with us if the obese patients,
Yes.
if there is testicular to estradiol ratio, if it is less than 10,
Correct.
definitely there is a role
If
of giving.
if when it is the palpating the was, if there is an absence of was,
Yes.
or if it is like Fesi told azoospermic means, then
Yeah.
we think about the cystic fibrosis gene and all.
See, the approach to male medical management, no, what I was just trying to drive home is this problem, this sort of thing. That, if you compartmentalize the male with a less count, you will arrive at 3 compartments. One will be a patient with hormonal problem, one will be a patient who will be having some infections, and one will be a patient whom you are dealing with oxidative stress. It's simple, you don't have to go beyond that. So what's your thoughts about infections in the male? Anybody? Yes.
Infections means
Yes.
one thing you have to see is whether it has been properly
Correct.
collected.
Correct.
And second thing is that whether it is morphology is stained enzyme, because immature cells otherwise will mimic like WBC.
Correct.
So we have to stain properly. And still if the infection is there and if it is more than 1 million,
Correct.
definitely there is a role for antibiotic.
Correct. So that was my question regarding appropriate antibiotic prescriptions. You should be very careful.
Infection should be distinguished from leukocytospermia.
Correct. Correct.
Both are not the same.
Correct. So many times we have semen analysis reports showing pus cells, pus cells, pus cells. What he is normally saying is that you should differentiate pus cells from immature germ cells. If they are immature germ cells, then there is no point in giving them antibiotics. Correct. What about hormonal treatment? We came blanket antioxidants for all. That is the next question that I think Fesi briefly touched upon. When we are talking about treatment, testosterone is the king of spermatogenesis, but my question is, are you giving testosterone prescriptions for male infertility?
No, it's counterproductive. It has the opposite effect.
All panelists,
If only if there is sexual loss of libido, we have to give testosterone, but that too, if it is given more than 30 days,
yes.
all the studies has found it will decrease the semen count.
So your answer is no, your answer is no, your answer Reggie?
Yeah.
Testosterone for male infertility
No, no,
patients?
no.
Never? Parshu? Never? Ashwath? Never? No? So that's the message that has to be driven regarding that. And then regarding your...
And one point.
yeah,
this thing.
make
Actually,
yes.
if you look at if you are prescribing an FSH, LH and testosterone,
Yes.
if you find FSH is low, LH is low and
Yes.
testosterone is high,
Yes.
then you have to ask them whether they are taking any anabolic steroids or anything like that.
Very important.
Especially-
Nowadays with all these young males going to gym, it is very important, no? And then see, lot of medicines, Fesi, you agree with this? Too much antioxidants, sometimes patient going to Gulf with 4 prescriptions, 5 prescriptions for antibiotic. Is it a problem or is it good?
It's a problem, definitely.
It is good because we'll have more stalls for Toxicon, but what's the problem?
For a general practitioner, you tell me, they are all from IVF,
Yes.
then what you will give? See, patient is
Yeah,
having a
what-
count of 10 million,
Yes.
okay, and patient is coming to you. You cannot directly first day it's about 10 million, you go to an IVF center.
No.
So you have to give something at least as a placebo. See, imagine, something has to be given to the male, he's telling count is low. You're telling no problem, they may not be accepting it. So we are forced to give.
No, I did not say that you should not give anything. See what is written there? Excessive use. There is a difference between use and excessive use.
So the problem is that, see, you give for 3 months, okay, it improves. Then will
No,
you
no,
stop?
no.
And see, simple, 10 million has become, patient has not become pregnant. The count has from 10 million, it has become 15 million, okay. So if you stop, if many times patient comes like this, 3 months to, then we stopped, then the count came down again. Understood. So our problem is that as a general practitioner, at least you should have to, female partner normal, okay, at least have to give something to the, otherwise the patient will not stay with.
No, that is not correct. Okay, I disagree with that. Anybody in the panel, or maybe I have to take opinion from somewhere down there, because the Parshu is sitting very silently. Something to give means what?
Basically, if the semen count is less, then as Ashwath told, we can try, but definitely there must be some underlying cause which has to be evaluated and
Correct.
found out.
Correct.
And there must be counsel if the count is less. As Ashwath told, if it is less, 10 million
Understood.
only,
You should
the
evaluate-
chance of conception even with IUI is less. That has to be counsel to the patient.
Reggie?
Although Cochrane tells
Cochrane
that
പോട്ടെ, Reggie പറയ്.
അങ്ങനെ പറയുവാണെങ്കിൽ തന്നെ പക്ഷേ we see if it in normal spermatogenesis you need lot of micro elements, lot of trace elements, you need lots are needed, needs supplementation. Suppose if there is a problem, there is no harm in giving
There is no harm. Only don't overdo it.
Yes, sir, I think what a lot of people should understand is that 70% of the OET we don't have a reason. We are still not able to find a reason.
Correct.
So we are giving some,
When I am sitting in my clinic, I see these prescriptions. 6 കൊല്ലം 7 കൊല്ലം all coenzyme, this and that. I think എൻ്റെ അടുത്തേക്ക് വിട്ടൂടെ, ഞാൻ അത് ശരിയാക്കി കൊടുക്കാം. അറിയില്ല. What to write means what? You agree, no? You also feel sometimes this is not fair.
See, patient, when they come to us, they would have visited so many clinics. So something that's very difficult situation.
Okay.
No,
No, it's not.
Venu,
Yes.
the reason is that pregnancy is always a chance.
Yes.
So with 10 million, you cannot tell you will not conceive.
Correct.
So if, as Ashwat told, if you give antioxidant for some months, sometimes you will get pregnancy.
That's all okay.
sir, can
That's
I
all
add-
okay. But there's a limit to everything.
Sir.
Now see, Fessy is sitting with Ashwath. They are foxy friends, so they will only talk a little bit.
I'm telling that you must send. I'm telling you must
Sir,
not.
one thing that my thesis was antioxidants in male infertility.
Yes. And what happened?
And I remember very clearly that there was a conference and one of my professors asked, that time when father was giving a talk, was asked him, what is the role of antioxidants in male? He said there's no role.
He said, no?
So he said the only thing is that you're giving them time. You're giving them more time. They assume that they're taking some medicine, they're trying. So
Yes.
you're giving them that much time that they will get pregnant during that time.
Well
And we
controlled.
assume that they're getting
Well
pregnant because of the antioxidants
Yes,
they're taking.
yes.
If the
Next,
count-
next
if
question.
the count is
No,
less,
not getting stuck on that. We had a reasonable debate. Antioxidants are not bad. They are not harmful. You could give them time to patients, but don't overdo. Nirmal, one statement about doing an ultrasound report detecting varicocele and going ahead with varicocelectomy just because, like what Ashwath said, എന്താ ചെയ്യാ പോയി അവിടെ പോയി varicocele ചെയ്യാൻ പറയും.
That's what I said. I don't endorse that view of looking for subclinical varicocele and doing surgery. Usually varicocele surgery is indicated.
Correct. Yes.
If it's done, it's done micro varicocele surgery for grade 3, grade 4 varicocele with
Correct.
decent,
What is written on the
decent,
slide? Yes.
decent testicular volume
Correct.
and poor abnormal semen parameters.
Parshu, endorse?
It's like, say, mild to moderate,
Correct.
no other reason
Ashwath,
for
debate
OAT.
illalo? Illa. Reji, no, Fessy, this we are moving now next. So counseling, then we'll move ahead from male infertility. We'll go to the next point. 6 minutes to go. So basic evaluation of female infertility, what, when and how. So this is the statement often described, and ASRM says that when you evaluate a female partner, we should be systemic, cost effective and expeditious. അതായത് സിസ്റ്റമിക് ആയി പൈസ ഒന്നും ചെലവില്ലാണ്ട് വേഗം കാര്യങ്ങൾ ചെയ്തു കൊടുക്കണം. How are you doing this? Yeah. Secrets.
So
All the general practitioners
basically,
would like
if
to know. Yes.
the menstrual cycle is regular, that means normally ovulation will be regular.
Yes.
And then it's like one normal ovulation study that
Yes.
will rule out any endometrial problem, uterine problem,
Yes.
any ovulation problem.
So
that
for
is the basic
first visit, ideally, when would you like to see an infertility patient?
and basically said
For the general practitioner also.
any time whenever patient comes, one baseline scan
Yes.
and detail history. That is the
Yes.
basic thing
Yes.
is necessary.
Yeah.
And if there is time,
Yes.
then we'll go for a one
Because
cycle of
patients call and
follicular
ask,
study.
doctor, enna vannu കാണേണ്ടതെന്ന് പറഞ്ഞാൽ what's your choice? When do you
I tell
patient?
that because if you too much stress initially for second or third day,
Yeah.
it will be a problem. We will tell them to come anytime, then
Yes.
we will do the proper counseling
Yes.
because there will be something else which
Correct.
you will be missing.
Correct, correct. You get maximum information from one first visit. How do you go about doing it? എന്തെങ്കിലും ഉണ്ടോ? Fifth day, sixth day, generally you call
No,
and then,
basic clinical examination, if clinical examination reveals something
Yes.
like a mass or
Yes.
fixity of the uterus, or history reveals that she is anovulatory,
Correct.
you go looking in the ultrasound, make a diagnosis.
Ultrasound is very useful for the infertility practitioner.
Yes.
Yes.
Just like females don't like to examine male.
Parishu കുറേ നേരം മിണ്ടാതിരിക്കും. Given a few investigations you would like to do to give you maximum output.
So today, I think, unlike what was earlier, one test that I like to do for all the patients that coming to me, female, is an AMH.
You are liking
Unlike
to
earlier.
assess the ovarian reserve.
Reserve.
I think we'll put it like that. Yes. Yes. Ashwath is waving his hand.
See, AMH, I don't disagree with him only because the AMH is a costly investigation for a patient compared to other investigation over in reserve. So
So
unless
you don't agree?
don't agree with doing AMH for all patients.
Anybody?
I also agree not doing IMH for all, only if there is some ovulation problem or if you are suspecting
Selective.
ovarian
You are
function,
still selective. Nirmal?
Yeah, if I see if I feel that she has diminished ovarian reserve on ultrasound, then I will do an AMH.
So definitely
Or
you-
all cases of ART.
All cases of ART, yes.
Day 2, day 3 scan showing low follicular count, AFC, if the andral follicle is
Yes.
less.
So
And if she is
nowadays-
having a shorter cycles,
Yes.
or if there is a history,
Yes.
if the sister is having a premature ovarian failure,
correct.
or anything like that,
Correct.
then you can
so
do.
if you want to be expeditious and you want to be cost effective, ultrasound is an important aid, no? That's what we are arriving at, Parishu?
Sir, because like I said, I very specifically said off late.
Yes.
Because earlier we also used to do the same thing of day 2. If you're doing a scan, we're seeing a good antral follicles. But then off late we have also seen that there are a lot of people who have a very, see today you end up seeing a lot of young women with low AMH. Earlier we never used to think of doing AMH in a young person. If only somebody is above 32, 33 or somebody who's got some ovarian surgery, we'll think of doing an AMH in your first visit.
Yes.
But today we are seeing a lot of women who's having.
Yes, I would sort of...
And even in the 2023 PCOS guidelines, I think AMH has come.
Yes, no,
for-
AMH is coming.
Yeah, it's coming, and a lot of research is happening on
yeah.
AMH.
And definitely you have to agree that the results are much better than what you
Even
were
on
thinking.
first miss, I disagree with all of them that doing a scan on second day, the patient may not be acceptable. On the first visit, I am telling. First visit, I don't
So
do it.
ultrasound helps us. What about these hormones like thyroid, prolactin, all this?
Everything. That's so the basic investigations like thyroid, prolactin, then FSH if needed.
You are doing-
These are the things which, in case, see, in case I suspect anything is a PCO or something is there, I add
So we
AMH
have to
to
be
it.
cost effective, expeditious. Nirmal, role of laparoscopy.
Venu, one more thing.
Yes.
AMH again, Gen 2 assay, very important.
Beckman Coulter assay you need.
Yeah,
Gen
which
2.
which lab and which machine they are using. That's also very important.
Important. No, but we correlate with. Now I think they are better off. Standard.
Yeah.
It's all the same.
Yes. So Nirmal, laparoscopy, epochia.
Laparoscopy, when you have these, first you see an organic problem,
Yeah.
like you see a
Yes.
fibroid
Roll
which
is
is
shrinking, no?
Yes,
Yeah?
yes.
Roll is shrinking.
primary endometriosis with a short period of infertility and a good ovarian reserve.
Yes.
Third thing,
Yes.
severe clomiphene resistance in PCOS, especially lean PCOS.
Yes.
Um,
So the role is limited.
Yeah, very limited.
Role is limited, no?
and
Shrinking,
hysteroscopy,
shrinking.
of course, you see
Yes.
any organic pathology within the
Yes.
uterus.
Correct. I think
In
that's
that,
septum,
that
polyp.
aspect, IMHS have got a great role because if you are suspecting
ഇപ്പൊ പറഞ്ഞു AMH ഇല്ലാന്ന്
in
പറഞ്ഞിട്ട്
this patient, what Nirmal was telling, there if you are suspecting endometriosis, but
This is must.
endometrioma,
AMH is must.
Definitely.
All
AMH
cases.
AMH I think Parishu, his view, I think we have to open our this thing to acceptance to AMH little bit more. But only thing we should know how to interpret it. That is AMH in a result കണ്ടിട്ട് possibility of having a baby പറഞ്ഞു കൊടുക്കാൻ പാടില്ല. Open our minds.
AMH, when you do unnecessary, see, we get so many patients with the AMH report coming to us telling that doctor has told that you will not become pregnant.
That is what I said.
So the problem
Actually, sir, I think we have to be very clear when we are counseling them.
Correct.
See, we know that people who have not tried at all, they come to you, we do an evaluation, we see a low image. Okay, we don't panically tell them that, okay, you need to immediately do an IVF.
Yeah.
Always give them,
Yes.
tell them the importance, tell them that they need to actually, in full effort needs to be taken to conceive naturally, do some small treatment, don't delay the treatment too much, give them a time frame, within the time frame they need to somehow conceive. And one more thing I like to add, whenever laparoscopy is done, considering that it's a general gynecologist, because the women with infertility goes, they see an endometriosis, they say, okay, let's do a laparoscopy, but they never forget, they always forget to see the male. That's what initially you were saying.
Yes.
It's always important that we need to see them as a couple, the husband and female.
No,
They
done, Chidu. Before we wind up, one last thing, breadwinners for all of you, to the general gynecologist, when to refer to you. Alabari, one indication.
So one
You have to
indication-
look there and tell them, please don't drag on this case.
severe
refer
male
to
factor
me."
infertility refractory to your treatment.
Which one?
Severe male factor
Severe male factor infertility refractory, don't drag. Yes.
also severe ovulatory problem.
Severe ovulatory
Ovulatory
problem, not
problem,
responding, don't drag. Yes.
Age.
Age.
Female age.
Age. Female age. Yes.
Yeah.
Very
More than
important.
35, you have to be very
Yes.
cautious.
Sir, severe OAT, low ovarian reserve, what is it? Third, very important.
ഒരെണ്ണം പറയൂ ഒരെണ്ണം
Only one is enough.
in the tubal pathology.
പരശു ഇപ്പൊ എല്ലാം പറയാൻ തുടങ്ങി ഒരുമിച്ച്
നമുക്കൊരു chance തരുമോ?
ഒരെണ്ണം വൺ
Tubal pathology.
Tube, endometriosis.
I'll know if everything is normal and they're not conceiving after you giving them reasonable time, it's important that you send
Nobody
them.
said endometriosis.
No, endometriosis is regular evaluation.
Especially recurrent endometriosis.
Recurrent endometriosis.
Recurrent endometriosis.
Endometriosis
Yes,
post-surgical.
Please,
Yes.
please don't
Yes.
refer patients
Yes,
with
Fessy,
0.1 AMH.
Fessy,
recurrent
Fessy
endometriosis.
goes around on social media talking about social freezing.
And
Social-
we send it otherwise also. I send it for nowadays that severe endometriosis and all. We send before for taking the
Cryopreservation.
cryopreservation.
Yes.
Social egg freezing is that even if you are not infertile, if
You
you
are
are
sending?
if the cycles are irregular,
Are you sending for social freezing?
we get lot of patients coming for
Are you
asking
sending? Getting അല്ല ചോദിച്ചേ.
for sending.
രജി ഇങ്ങനെ മിണ്ടാണ്ടിരുന്നാൽ മനസ്സിലാവുക ചെയ്യില്ല
ഇല്ല, social egg freezing we are not.
സോഷ്യലി ആൻഡ്